we talk about control of blood pressure and we're thinking about primary prevention of stroke or heart attack, I think more intensive therapy is better. If you look at the population-based studies, patients who are controlled at blood pressures that are closer to 120/80, closer to sort of an optimized blood pressure, have fewer cardiovascular events as a consequence. So it used to be that we were shooting for targets that are a little bit more lax, thinking that there was a wider range of variability that was acceptable for risk. However, it really seems that excellent blood pressure control is better than good blood pressure control. And so intensive therapies targeted toward controlling the blood pressure well, and I often tell my patients, we want every blood pressure to be within this range if possible, but not at the expense of hypotension, not at the expense of the blood pressure being too low, because that's when we get complicating events like lightheadedness, syncope, falls, situations that may cause morbidity in patients who have low blood pressure. But in general, intensive blood pressure management is a much better approach for long-term reduction of stroke and other cardiovascular events. If we think about medical therapy regimens and what are the negative impacts, I think it more is geared toward the idea that we're producing some relative amount of ischemia, whether it's ischemia to the kidneys or ischemia to the brain or elsewhere. It's often more of a global sense of ischemia rather than a focal process. And I think we have to remember that if, at the primary prevention level, the blood pressures that are currently part of the recommendations are all normal blood pressures in which patients should not experience ischemia as a consequence. However, the more aggressive you are at lowering the blood pressure, the more likely there is to be these other complicating events of low blood pressure or hypotension. So other than that, there really aren't major complications of these therapies. There are side effects of medications. So whether it's, peripheral edema in calcium channel blockers, it may be urinary dysfunction, frequent urination in some patients with diuretics. It might be other side effects that are relevant in specific populations. I think what's really important is excellent blood pressure control is better than good blood pressure control for reduction in stroke and cardiovascular events. The side effects are the risk, right? And those side effects are substantially less than the benefit. So the benefit is greater than the risk. We recommend this strategy. No, I think it's less that there's been a few more fluctuations, I think, in the secondary prevention targets than there have been in primary prevention targets. But remember, there's so many advantages to control of blood pressure outside of just the reduction in ischemic events. Long-term hypertension causes additional strain on the heart, additional strain on the left ventricle, patients develop left ventricular hypertrophy. Anytime you work a muscle more because it's having to pump against a stronger pressure, it's going to get bigger and thicker. Left ventricular hypertension is often closely associated with the risk of other types of events associated with the end organ damage from hypertension, whether it's renal disease, eye diseases, brain diseases. Most of the disease is in the small and larger vessels that are affected in these vascular beds by uncontrolled hypertension over time. So uncontrolled hypertension is so significant in terms of its risk of causing cardiovascular events that the control of this, and even with a small increase in risk of hypotension, is still well warranted. And whether you're talking about the secondary prevention population or the primary prevention population, there's still a huge benefit to control.